The topic is gap design. So now I'm going to slow up a bit, because I know you knew the other stuff. Now I'm going to slow up because I think this has ability, what I'm going to show you today, might change some of the way you practice, I think, on Monday. And I'm being serious about that because this is something I've been talking about for about 3 years. We didn't have verification and proof. You're going to see proof today of some concept of proof of principle at least, with a special case report. What happens when you have this gap in here? There's a whole big discussion about what happens in this one area, right, in this area here. So what happens in there? How does it fill in? Obviously a clot will form. Should I put bone graft in? Should I not? Should I put the flap over the top? Should I not? Should I temporize? Should I not? Should I submerge it? Should I not? What bone should I use? Should I put a membrane on? We forgot that. What do you do? What's the best thing to do? So let's go back and look at wound healing. Here we are in the year 2009, and I'm letting you know that we have very limited understanding of how a socket heals up till now. I think we're starting to really understand it much better than we ever did. Let's go through this. Bear with me. All these articles and others have shown what? That if you have a distance greater than about 0.5 to 1.5 millimeters between the buccal plate and the bone, this gap distance will fill in with what? Right up against the implant, you will get a what? A fibrous seam, or an epithelial or fibrous seam. So everyone talks about the 1.5 millimeters for sure. If you have a distance between the buccal plate and the buccal part of your implant, the facial part of your implant, more than 1.5 millimeters, you have a potential of getting what? A fibrous seam. And Wilson even showed that in humans. So, I went back to this literature and I realized there was a problem with the literature. As well as good as some of these articles were, what did they do? After these implants were placed, they did primary coverage over the top. And why is that what I think is incorrect to do? Akimoto and Becker, I'll just use his article. It was probably one of the cleanest ones done. You could see that they made implants with openings at the top, buried at the bottom part, and created different openings at the top. No gap, 0.5 millimeter gap, 1 millimeter gap, 1.4. And then they, of course, didn't put a membrane in. If they put a membrane in, they would get bone up against the implant. It would block the fibrous tissue from the flap. But what they did here, in all the other cases that were done in the literature, what did they do? They did primary closure. And as a principle, that's good to do, see what happens. By doing that, clinically, they all look good. But histologically, the gap definitely had its effect. The control with no space, you see the red is the bone, of course. The bone is right up against the implant, just like we'd expect. But what's this? What is that? That's fibrous tissue. On the 1.4 millimeters, you see the fibrous tissue down the side. The implant integrated at the bottom, but you had this fibrous tissue. What happens is, if you put the fibrous flap, the flap with connective tissue, of course, underneath it, over the gap, it has a blood supply. The flap has a blood supply. It's a pedicle. And that blood supply can travel down into the clot against the implant faster than the bone crossing the gap, which is what we want. We want the granulation tissue, the new blood vessels and capillaries, to come from the bone, which is pre-coated to form bone. That's what we need to get there first, but that's slower than the connective tissue from the flap. Just like an infra bony defect on teeth, same kind of problem. Okay, so what happens here? So what happened in here? No, I didn't put anything in there. There was a buccal plate. By the way, with 4 lower anteriors, this is what we do routinely. Our group, Steve Chu is here from my office. I have 7 partners in my office in New York, and we do this routinely. We just produced a paper with 10 consecutive cases, 4 lower anteriors coming out. We take the best 2 out of 4. The best 2 on, don't do 2 on one side, but the best 2 out of this side, the best 2 out of this side, and we load them. Yeah, I said, can I do 2 on one side? No, that's stupid. But take the best 2 of these, we put the immediate implant in the singular, aiming at the cingulum. There's just 3.25 millimeter type implants. You can do the 3.7, they go beautifully in here. And then you leave the space, and now this is just clinically sealed. This is 12 weeks later. And there's the bridge. 12 weeks later, I cannot probe this. No graft was put in there, nothing. Now this is just a clinical case, but like Becker showed, clinically it could look good, but what's up against the implant, between the bone and the implant? That's still the whole story. So let's talk about primary flap closure versus secondary wound healing for a second. You take a tooth out, all the walls are present, it fills with a clot. Now what happens is, people think that this clot is blood vessels. The clot is a clot. It's dead cells with fibrin. Ain't no vessels in there. Ain't no blood in there, no vitality in there. You got it? So even though there's a clot, and we need that to protect the bone from a dry socket and all that stuff, you must realize that epithelium and connective tissue can't migrate over this. Why? If you injure yourself, real quickly, if you injure yourself, why does it take, this is all, you've been drinking. Lou, you've been drinking too much. Okay. That was last night. That was scotch. I didn't drink scotch until last night. My God, you guys are ruining my life here with scotch. Okay. All right. Okay. If you scrape yourself, and the distance is about a 10 millimeter diameter, you scrape your knee. How long does it take for you get a scab, and how long does it take for that clot, the scab, to be eradicated? About? What's the rate of epithelialization? About a half a millimeter to a millimeter a day. And where does the epithelium go? Does it go over or under the clot? Over or under? Has to go under. Why does it have to go under? Because it can't go over the clot because it's dead cells. This is fibrin. So it has to go under the clot because epithelium doesn't have any blood vessels of its own. It has to go under the clot to get the vitality and blood supply from the connective tissue under the clot. And then it works its way around the edges and eventually at the rate of, let's say, a half a millimeter to a millimeter a day, and then it peels away. Now, so a 10 millimeter diameter opening, at figure 1 millimeter a day from each side, how long will it take for the clot to fall off? About 5 days. I'll give you a week, okay? There's a little delay period. All right. Now your clot is about 8 to 10 millimeter diameter maybe. Central incisor, maybe 8 millimeters diameter. How long does it take for it to epithelialize? What did Amla say in the 60s? In humans. It's much delayed. Why is it delayed? It's delayed because of the fact that it can't migrate over this clot. Tried to go under the clot. But then the granulation tissue is coming in, and it's by contact inhibition. The epithelium doesn't go down and line the opening because the granulation tissue has to come across before the epithelium can come across. So the granulation tissue from the bone has to come across first. Because the difference is, take a look at the top of this cup, that's the opening. That's different than the bottom, which is like your skin, with this connective tissue right underneath the wound. Whereas on the clot, on the socket, you have a situation where there's a clot in there, but there's no vessels in there. It's got to be delayed until the vessels come across first. You all clear? So how does that affect what we're doing? Leave it open to heal by secondary intention. That was my thought for years, biologically. So let's take a look. So it would slowly move in to be like this. This can't go any faster. This part at the top cannot go any faster than this granulation tissue filling in from the bottom and from the sides. So this is the kind of mechanism that you'll see. So it has to move in from the sides. It goes in and slowly migrates. This is delayed, though, until this comes across. All right. So that concept is pretty much true. I discussed this with Sig Stahl, who's like my mentor. He's like Adriano is, in Italy and the world. Sig Stahl is my mentor. And so this is what we know, and this is all valid. This is all pretty well established. And Amler in the 60s did this work. What happens if you put an implant into the clot? Let's put an implant in. And don't pull the flap over the top. What's the concept then? My theory is that the epithelium can't come across. That this bone has to come across first, and this would be delayed. And that if you put the implant in and don't hike the flap over the top, that this should get there first, no matter what the gap distance. Here's the part to think about. There is no gap distance when you don't pull the flap over it. There's no critical gap distance. I think that rule is going to be thrown out, and I think I'll show you proof of principle today. Okay. And the bigger the gap, it doesn't matter. Because it's going to take time to come across, a little more time, but this can't get down there until the granulation tissue comes across. That's the theory, at least. Okay, so let's move through this. Now, by the way, what about pulling this flap down? There's a few things wrong with that. What's wrong when you pull the flap over the top? There's 3 things that you violated, as far as I'm concerned. We don't have too much time to go into all 3, but understand that the blood supply to this buccal plate comes from 3 sources. One is the ligament, but that's gone. You took a tooth out. What's number 2? The periosteum. And if you lift the flap up to close it over, you have interfered, even though you put it right back over the bone, for 2 to 4 days before it reanastomoses with the blood supply to the periosteum, you've interfered with that buccal plate's blood supply for 2 to 4 days. And number 3, it depends on how thick the buccal plate is. Is there marrow? The lingual usually has much more marrow. The buccal is, of course, much thinner, as you all know. So that's a violation. So what are the 3 violations if you pull the flap over? It looks so innocuous, doesn't it? It looks so easy and so innocuous to do, and instinctively you want to do it, but what the problem is that you've brought the connective tissue right over to migrate down. And you've also moved the mucogingival junction sometimes into the aesthetic zone, and that is sometimes not so nice to reposition it. So the problems with flap and primary closure in the socket is the mucogingival junction is now potentially in the aesthetic zone. You've exposed the buccal plate for the possible increased resorption, and you've allowed flap connective tissue to get down the implant first, and that is the real negative. That's where the 1.5 millimeter rule came in. What about putting a graft in? Without a membrane? Just because there's a hole there and you stuffed something in there, it makes you feel better, but it does not stop the connective tissue from getting right down against the implant. It's like the long junctional epithelium on teeth. Without a membrane, have a good day. You have not developed any kind of blockage to these cells, and this is just a clot filled with particles, and this comes down and pushes them away from the surface, and when you look at this healing, you don't see the particles healed up against that implant. They get pushed around and moved away. Okay, so that's, unless you put a membrane in, then of course it would work. Then you got to reposition this back. So if you look at this patient I did, this patient here, you can see this is a patient I did with Steve Chu, who was in the audience. You can see this guy's resorption. Let's go through a couple of cases real quickly. You got this resorption. I take this out as atraumatically as possible. Now what do? The buccal plate's definitely there. I place it towards the palate, as you all know. There's a gap distance. We place it towards the palate. And this is all the contour stuff that we heard a lot about, flat contours. And I think, Marco, you did a beautiful job yesterday, Marco, of showing that, is that you kind of flatten the contour underneath the tissue, then you come out with a normal contour. Everything is flat. That goes back to Weisgold's work, even on teeth. Flat profile, lets tissue come down. Over contour, tissue goes up mid-facially. So this is what takes time to make this beautiful temporary. That's when you take the time. Place the implant correctly, and then you as a restorative dentist or your team, take the time now, and you're basically done. There's the contour that you look for, straight underneath, then your normal contour. And this is what it looks like immediately. This is a pretty thin tissue. 1 week later, you can see we've been able to maintain everything, and there was no clot. There was only a clot placed in here. 3 months later, as you see here, and this is 5 months later. Now here's something interesting. Notice that this is the first time we took the temporary off. What do you see? What's that? It's blood. That we actually had adherence. Remember one abutment? That we actually had adherence, and that's the first time you take an abutment off, you usually see bleeding. If it's been in for 4 to 6 weeks, you see bleeding, because you're ripping the junctional epithelium. Think tissue, think biological. Okay, but that's okay, but there was no pocket depth there. Then we just had a custom abutment made, and here's the final crown in place. And you can see that we had something I think pretty nice as a result. It's the day of insertion. Here's the implant placed. Everything's fine. This is even without a platform switch. So because single teeth over here, it's not a major factor because the adjacent teeth hold everything up. And this is what we started with, and this is what we have afterwards. And I think you agree that we got a decent result, and it looks pretty natural, even close up that way. Pretty patient. Now what if we put a graft in? I think we're going to start putting grafts in, but it's not giving you what you think it is. It's not to try to regenerate bone against the implant as much as if you do get reshaping of the buccal, which certainly can happen from the injury of the extraction, then this moves in a little bit, but you hopefully will prevent the collapse too far by using the graft as we've seen, as Marco showed yesterday. So I think what we will be doing is placing grafts like this. Here's a tooth that has to come out. It's got some huge internal and external resorption. You see the pus coming out, couldn't be saved. Place the implant, big gap. In this case, what? In this case, I just put an abutment on and packed this with some bone graft material, just like belt and suspenders. We may or may not need this. I think we're doing more research to see how much collapse, if any, we get when the buccal plate's present. Now this one, we just put a temporary on, a flipper, and that was all. We let this heal. You can see that at 3 weeks, you can see the particles of some of them working their way out. It's not completely healed yet. This is what it looks like in a few months, and then we sculpt the tissue. Sculpt the tissue with pressure, nothing else. No other surgery was done. And then you have this is the temporary that was used from the flipper, and you can see we've been able to preserve the tissue, and here's the final crown in place. This one I did with Dr. Brown, one of my other partners, Marion Brown. So you can see that we can preserve this, and nothing was done surgically except the extraction. This one did have a graft in there. Would it look as good if I didn't put the graft in? I don't know. We need standardized controlled studies, which are difficult to do, because we also don't know the thickness of the buccal plate easily to measure. It's not so easy. And at what point do we measure the buccal plate? Do we measure it 1 millimeter at the crest, 2 millimeters down, 3 millimeters down? This is part of our clinical problem at the time of extraction or afterwards. How do we measure that? I think the CT scans are always not enough. Now, the last piece, the gift. This is a special gift from a patient. I was told to Anthony I wouldn't use his name, but he said he was a real ham. He says, I asked him, I told him it would be anonymous. this is a case where a cuspid had to come out. It was a serial extraction case that I was doing with Steve Chu, as I mentioned, one of my partners. And we had this case all, very well documented, and he had a very large cuspid. I took it out and put the implant in the cusp, in the palatal area. And look at the gap. Look at the gap. What do you measure? 4.1, 4.2 millimeters, over 4 millimeters. What do you have there? There's no question that this is beyond any gap distance that was in the literature as being questionable. It's not like, well, it was 2.1 millimeters, this is twice the size of any gap distance that they say that you should not be able to get bone against the implant. If my theory is right, leave this open, let it clot form. I did. Notice at 1 week, you still got a fibrin clot in there. Tissue collapsed it over a little bit, but this in there is just a yellow fibrin clot. Look what we documented. This one was unusually long. At 6 weeks, you see this granulation tissue coming up and right into it. All that was there was a clot. That was it. And then you can see this 9 weeks. Now it's epithelialized. 3 months. Then we waited 5 months because we were doing a whole mouth of work on this guy, on Anthony, and we went from this to this. Now, we got some collapse from 4 down to about 3.2. You'll see that in a minute. And this is the implant sculpted and loaded for 3 months. So this is now 9 months post-op. Is when I spoke to the patient. Steve said, boy, if we could ever speak to Anthony. And Steve did, and I did. And he's a lovely 75-year-old man. And I said, we put this in as an extra implant anyway because in the aesthetic zone, we wouldn't have even put it in. But I said, Anthony, you have such an unusual case for science. We'd like you to consider it a gift for science. And it's the way it was approached. I don't take this lightly. This is not, I've never done this to a private patient or any other patient without research oriented at school. And even then we think twice. But I said, this will not hurt you. You have a low lip line. The worst that happens is that you'll have the same bridge, there with without this tooth, but I'll rebuild the ridge and put a new implant in at no cost, and I'll give you a sizable, and Steve and I'll give you a sizable reduction, mostly from Steve's income, not mine. And so he agreed to it. I said, you got to come back 3 times. Steve was doing a lot of the prosthetics. I said, come back 3 times before I'm going to do this, and we're going to sign a release. You have a low lip line, I'll rebuild the ridge, and I'll give you a reduction. He did. He came back 3 times. He says, I'm ready to do it. I'm ready to do it. I said, I won't use your name. He said, no, you can tell everybody who I am. He was a real ham. He says, tell everybody. So it's Anthony Prolongo. And we did this, and so we did this scan, and we can see that we had 3.1 millimeters. So we did get some outer resorption of that very wide piece. But the question is, what's up against the implant? What's up against the implant, even though we filled this with bone? So this is what it looked like the day I took it out. Okay, you can see this right here. It's sculpted. Sounding was normal, absolutely no pocket depth. I took it out in block. I left part of the buckle in as a shelf. I then just rebuilt this with some bone. And this is what it looks like at 1 week. This is what it looks like at 2 months, and we didn't do any harm to this patient. We're waiting for 6 months. You can see the graft at 2 months is filling in nicely. Well, I'll just put another implant in for him and call it a day. There's the modified block, as you see here, with the bone attached. I attached a healing abutment so I could hold on to it. What's up against between the bone and the implant will tell us whether or not the concept that I have was right. I did a micro CT. You can see the bone. This is the buckle. The micro CT did show that there was bone right there, but you still have to see histology. There's the block. What's that? That's bone up against the buckle. There's the blow-up of it, as you see here. Bone right up against. Minimum pocket depth, 0.5 millimeter at best. Epithelial attachment, connective tissue. And this is a non-platform switched implant, so this will be about the first thread, about 1.5 millimeters down, and that's exactly where the bone was, even though this was entire bone fill. So let's go blow up of that again, and there's your first thread, with bone being right up against the implant and the connective tissue coming down. A gift from the patient. Proof of principle. So where does that leave us? That leaves us with the fact that we have a situation where without primary closure, leaving it open to heal by secondary tension, similar from the periodontist room, what Pritchard talked about intra-bony defects, cutting away epithelium and connective tissue, goes back to basics, goes back to wound healing, goes back to biology. That in fact, there is no gap distance that's critical if the buccal plate's present and you put the implant in. You want to put a graft in anyway? Sure, it'll give you that little extra security. But the critical thing is the wound healing without a graft, with just a clot, you're in fine shape. I hope you appreciate the gift, and thank you so much for giving me the extra few minutes. Thank you.